All right. Hello, everyone, and welcome to the Commure podcast, where we sit down with clinicians, executives, and innovators shaping the next era of healthcare to explore how technology is transforming the way care is delivered. I'm your host, Dr. Jean-Luc Neptune. I'm the executive medical director at Commure, and today I'm joined by Dr. Chethan Sathya, who is a pediatric surgeon and vice president of strategic initiatives at Northwell Health. Chethan, great to see you again. Glad to connect. And if you'd like, why don't you do a quick introduction of yourself? I know you have many other titles beyond just being a VP of Strategic Initiatives. So tell us a little bit more about yourself.
Absolutely, JL. Thank you for having me on. As mentioned, I'm a pediatric surgeon clinically, still practicing about 50% of the time. So that is the bulk of what I do within Northwell. And under the vice president title, I largely work with health technology companies to understand from an implementation science lens, which is my background. How can we think about implementing technologies within health systems from a clinician usability standpoint, from a scaling standpoint, from a healthcare setting standpoint? Because one of my biggest frustrations, I think, during the pandemic years was I saw a number of folks investing into health tech startups that I knew would just never take off, right? They just didn't make sense for my workflows. They didn't make sense from an implementation or usability standpoint. And that's kind of why I got really engaged.
Got it. Sounds good. And,
Yeah,
it's funny, like, question is, did the pandemic ever end? But I get where you're going.
exactly.
All
Yes,
right, great.
yes.
So you talk about this is a perfect segue to start this. So you talk about seeing a lot of technologies, and I remember some of these gigantic investments in technologies that I knew that I was skeptical about for sure. But it feels like something has changed pre-pandemic to post. It feels like we really have technologies now that are fundamentally changing the practice of medicine, which is something that in my career, I've seen a lot of technology come to market, but very little of it has fundamentally changed the way providers operate. So I guess
Mhm.
my big question to you is, given your clinical exposure, where you live now, what has actually changed in the hospital setting, ambulatory setting, home setting, whatever setting you want to choose because of artificial intelligence?
A great question. And I definitely want to get your take on this as well. I'm curious what your answer is. I guess I would preface it by saying all the discussion, the hype around AI and so on, there are some areas that I think have started to fundamentally change. However, one thing I would push back on there is I think my day-to-day practice or what I see on the front lines, I don't think things have actually changed that much yet. I think we're just on the cusp of that happening. When I think about how physicians saw patients 100 years ago, or how we do operations right now, it actually hasn't fundamentally changed that much, right? I still wait to see a patient. That patient still waits a matter of weeks or months to see me. They do not arrive to my clinic with the correct imaging, with the correct clinical labs that were necessary to be drawn. I then see them. I then order additional tests and then see them 3 months later, and then maybe book a surgery, right? And that process flow in itself hasn't fundamentally changed. The way that I operate, I don't think has fundamentally changed. Yes, we have things like robotics. I don't think we've integrated AI to a substantial level yet into that. I still have to make cuts through the skin. I have to dissect tissues. So I think we still have a long way to go. Um, a couple of the obvious areas that come to mind, of course, would be ambient listing. Certainly, when it comes to documentation, if you think about the ways that we still hold on to our medical scribes in our clinic, ambient has really started to change the game there from a documentation standpoint. That's been tremendously exciting. I know Epic and other EHRs have also integrated AI workflows and other startups as well into our clinical documentation, our reasoning, and so on. So I'm starting to see changes there. Radiology, pathology, definitely seeing some significant advancements there in those workflows and ability to detect different diseases and different lesions. And then there's the administrative stuff on the back end, whether it be pre-surgical testing, surgical efficiency, where I think we're just starting to scratch the surface around really fundamentally changing things.
Got it. It's very interesting that you say that, the way we practice is largely unchanged, right? I wouldn't say 100 years ago. I'd say more like 40 years ago, right? Because
Yeah,
remember, 100 years ago, like, it was a totally different world, right? But I'd say
yes.
that, the way that providers practice now from the standpoint of a third party reimbursement, a fee for service system, I'd say very much we are still practicing in the ways that we used to practice before. And I think that is entirely a function of what we pay for, what we pay for in the system. We focus on the inputs, like what are you doing, rather than the outcomes that you're trying to create, right? And obviously,
Yeah.
the whole idea behind value-based care is moving away from that model where it's all about what you do as opposed to what you create from the standpoint of outcomes. So I very much agree with you that the way a provider, let's say, sees patients in a queue and the way that patients are coming down the queue, like the structure of that queue hasn't changed very much, right? Again, it's like the patient has
Yes.
to come in, they have to give all their information 10 times, they have to, fill out all this paperwork. You as a doctor go see the patient, then you have to do your paperwork. So a lot of that hasn't changed. And I think we're going to need changes in the business model and the way we pay for healthcare to see fundamental shifts there. And we can talk about that a bit more in a second.
Yeah.
But
Yeah.
I do,
And and
go
and
ahead.
and just to that point, I mean, I think you're absolutely right. 100 years is probably the wrong time frame, right? I think that's more applicable for some of the infrastructure things that I was referring to. But you're absolutely right. It's probably better to comment on kind of our move into the digital age with the internet, and how we search for information and so on. I would equate it more to that probably, in that whether I use AI right now for some of my clinical reasoning or what I did back then, it's getting better, but we're just starting to scratch the surface, whether you're talking about open evidence or, ChatGPT and so on.
Yeah, for sure. And generally what I tell people is, my dad was a doctor. So I always say that the way we practice medicine, despite all this new technology in our lives, the internet and all that stuff, like we still practice from a day-to-day perspective, very much like my dad would have practiced in the 70s, 80s, and the 90s, right?
Yeah,
But
exactly.
I will say that I'm really a believer that ambient is the first technology of all these technologies, let's say in the modern digital age, the post-internet age, that really changes the way providers work and
Yeah,
allows providers to be more effective, to be happier, to provide better care, and to do so more efficiently. And I've seen that, at Commure. I work with some of our largest clients on their deployments of ambient, and you see it in the data, right? You see doctors who are happier because they're using the technology. They're seeing more patients. We're looking at the patient feedback. The patients are like happier because the doctors are talking directly to them now. The patients go look at their open notes and they realize like, wow, like the doctor captured all my details, even though it's really the technology capturing the details of the discussion. So I definitely think that is
huge.
the tip of the spear right now and truly transformative. And so transformative that hospitals and health systems that are traditionally reluctant to move forward with technology, we're seeing like 80 to 90% of hospitals and health systems are either actively deploying or are trying to deploy ambient
Yeah,
within the last 2 years. And that
yeah,
is a fundamental change from however hospitals have typically embraced technology.
yeah. And I mean, Northwell's in that category as well. And that's why, ambient was the one thing I wanted to point out in that answer there, because I totally agree with you. Just if you think about how much documentation we are required to do, how inaccurately we do it as well from a billing standpoint, from a documentation standpoint. I mean, I think Ambient is already changing the game there. And it's been incredible. It's just been absolutely incredible. And, I even remember a time where, for example, medical scribes that we currently have were not a thing. I
Mm-hmm.
trained in Canada, right? Like when I was resident, it wasn't really a thing to have a medical scribe there with you all the time. Even that step is a game changer. Now,
Yep.
ambient just takes that to a totally different level, right? But I mean, just even that small step of back then, just for folks who are listening to understand how big a change that just a medical scribe made. This is just accelerating that on so many different domains because you can listen to so many different things in so many different settings in a hospital.
For sure, for sure. So after ambient, I think there is a second tier that is emerging that is going to
Hmm.
change the way we provide care. I think first there is like what I would call the intake suite of technologies. So going back to what I
Hmm.
was saying before, so much of the challenge of being a doctor and a patient is being asked the same questions over and over again, filling out clipboards, filling out, portals and all different stuff that we ask patients to fill out. And then as a doctor, at the end of the day, you still have to like pull all this information together and create a narrative around that patient, right? I think there is the next stage of really useful technologies is what we at Commure call like intake, which is essentially taking
Huge.
a patient's story that they tell you, they're talking to a voice agent who's taking a history, or you have a technology that's looking at a patient's chart and summarizing that chart, and then being able to give the provider a cohesive summary of who this patient is, why they're here, and how you can help them, right? I think that that is like a emerging technology that is going to be, that we're already piloting right now, that I think is going to be very real in the next, let's say, year or 2 years, changing the practice for providers. One other, and then I'll pause, is I think a clinical decision support. Like we've been trying to crack this clinical decision support nut for how many decades now, and have never really been able to do it well. But I think that now, we're moving in that direction where we can nudge doctors in a very subtle kind of way. In fact, we have a technology called care cues, which is like giving doctors subtle nudges to say, hey, listen, did you remember to do this? Did you remember to do that? In a way that's very contextual and very, very subtle. So it's not viewed as intrusive, it's viewed as helpful. And I think that that's another layer of technology that's going to be very helpful in the near term.
Yeah, yeah. I'll comment on both those. I mean, I think from the intake standpoint, to my comment earlier, huge area of opportunity. And you're absolutely right. I mean, from a technology standpoint, as Commure is articulating and building on, I think something that's easily solvable and that health systems desperately, desperately need. If you think about, improving our access, for example, to specialists or primary care, if you think about optimizing clinician time for improving throughput, I think that's huge. And you're absolutely right. I mean, the fact that we still take a history really that is not pre-populated with much except the prior visit, if there was one, is kind of crazy, right? And so I think that'll absolutely change the game. And on the second piece around clinical decision support, yeah, I think one of the I guess issues I see with our field at times is that there's a reluctance to embrace AI as it's being developed, and we all know the models are going to change, right? There are issues and errors that happen, but my argument is always, I mean, how many errors do we currently make? So many clinicians' decisions are subjective, right? If you think about the most experienced clinicians in the country, it's not that they're necessarily ingesting the latest evidence better than someone else. It's actually probably that they have a larger experience. So they're going
Yep.
off of anecdote and, years of experience. Does that mean it's the best care? Does that mean it's actually integrating the latest data? Absolutely not. So I think it's a disservice not to integrate AI rapidly into clinical decision support. And yet, you're right. Folks might feel like, are they concerned it's going to be intrusive and so on. I think we have to switch that mentality. Why would we view it as intrusive if it's really going to fundamentally change and improve how we can offer care? I mean, you literally are getting 3, 4, 5, 100 opinions all at once through these large language models potentially as they improve their accuracy and effectiveness. So I think we got to shift our mentality there.
For sure. And couple of points of discussion to come out of that. So first, what I always say is when people talk about their concerns about hallucinations, right? And mistakes that the AI is making, I always tell them, like, have you ever been in a hospital? Have you ever been in a doctor's
Exactly.
office? Have you ever seen
Exactly.
like how many medical errors human beings make in the course of day-to-day practice of
Yeah.
medicine? Like,
Yeah.
humans are massively fallible and we make so many mistakes. And I think that, we have to, as you said, get out of that mindset of like, the human mind is better than a machine, because the truth is we make a lot of mistakes. And if we can use the technology again in a non-intrusive, contextualized kind of way, we can make providers better. I've always argued that there are second and third order benefits that we're going to achieve from this technology, like reduction in medical malpractice, because we're going to make fewer mistakes. We're going to be able to document better so that we don't get sued as providers. So I think that those are benefits of the technology. But it raises a very important question. You and I are on the cutting edge, right? I've been doing this for almost 20
You've
years
been,
now. You've been doing your thing for a while there. I have a feeling that most medical schools and most residency training programs in particular are not really doing anything to train doctors for this future, right? They are
Mhm.
still trying to train doctors the way we used to train doctors like in the 1950s. And you work in an academic medical center, you're in an academic training program. What's your perspective? Are we training the doctors of the future for this technology?
No, no. Just like we're not training our current workforce to the same level that we should be. Now we're starting. This is a gargantuan effort, and I think, health systems like Northwell and others are rapidly trying to understand how they can educate the workforce, how they can improve digital literacy. How do we integrate it into our medical school? I know our med school is relatively younger than others, and there has been a big push to try to integrate these learnings into that curriculum recently. But again, that's just the start. I think it's absolutely essential because otherwise, folks are going to continue to feel, in my opinion, threatened by technology rather than wanting to embrace it. Because there's all these fears, right? And, just like any other sector. Hey, are our jobs going to be replaced? Are fewer of us going to be required? But I think that education at a very young stage is very important, to have physicians not only be aware of technology, but to be able to excel and be the ones controlling it, for our future workforce. I don't really think it's as big a threat to our jobs as we might think. And I think that's an important point, JL.
Got it. And, part of this discussion today is like, and part of what I spend a lot of time thinking about, and I don't know if many other people spend time thinking about this, is like, what does it mean to be a doctor in a future where the computational power that we select for now is actually exists in a computer? What I always tell people is like, the doctors that you see emerging, coming out of a residency program, we started selecting them when they were like 18 years old in college. And, they demonstrated that they were good in chemistry. They were good in organic chemistry, in physics. They showed that they could get high scores, and they could essentially do these mental calculations that we typically do, right? So again, think about looking at a blood gas in a hospital, right? Or, think about all the mental calculations that we do as doctors. In a world where the technology can do that stuff better, faster, cheaper than the
Yeah.
doctors do, it feels to me like selecting doctors on that behalf or on that basis is not like a smart way to select doctors. So like, what do doctors like? Is the skill set of being a doctor going to change? Like, what are you going to need to be good at to be a doctor in the future with all these technologies?
It's a great question. Great question. And we could go in multiple different angles there. I guess I'll just start in a very straightforward way. This is where technology is going to be leveraged in order to maximize doctors being doctors when it comes to that human touch, you know, empathy for a family. How do you actually interact in a social situation? I think, just to be frank, medical schools across the country, I don't think they've done an exceptional job assessing EQ, right? Emotional
Absolutely.
intelligence, or the
Absolutely.
ability. And if you look at physician leaders across the board, I would argue that many of them actually, the folks that excel in leadership in academic medical centers tend to be grant heavy researchers who have very little in the way of EQ.
Absolutely.
They're not what you'd consider a leader in health technology or in politics or someone that motivates and so on. And so I think there's going to be a tremendous shift there, right? On one hand, who are the people that can innovatively, you know, know know how to interpret what AI outputs are, right? So be able to work with technology, but again, obviously intelligent folks who know how to interpret that. But then on the human side, who can really then navigate that human touch? Because I do think of all the things we talk about, that is the one thing that a physician really needs to hone in on with patients. And I don't think technology is ever going to replace that. I do think a lot of the other things we do, it's not that technology is going to replace it, but they can very much, technology can optimize it in many different ways. So I think medical schools are going to have to look at that in a very different way.
Got it. And you hit upon the EQ part again. I mean, I definitely saw this in my own training that, again, we selected people not so much on their empathy and their ability to connect with patients as much as their technical skills or their memory or their ability to synthesize, the latest studies. And I think it reflects in the experience that patients have, right? Like when, how many people do you know who've gone to a doctor who are like, the doctor did a great job, but I felt like I was just a piece of meat, or I
Tons.
felt like, I felt like the doctor didn't care about my concerns. And I think hospitals are increasingly thinking about those things now as they look at NPS scores, as they look at, patient satisfaction scores. But I still think that we're not like backfilling to try to promote the most empathetic kind of people. And it's interesting, do you have children?
Yeah, three kids.
Three. So I have two kids. My guys are a little older now, in high school and one in college. But I distinctly remember, like when they were in school, there was a whole curriculum, like social emotional learning (SEL) curriculum, and it's almost like we have to, in a world where you're not going to be a walking computer, you're going to have to be really good at like the patient engagement interaction piece, and it almost feels like there's got to be a social emotional learning for med students and residents and even attending physicians, because I think that's
Totally.
it plays such a huge role in how we're able to deliver care and help people achieve good health.
Yeah. Yeah, absolutely. And I mean, I think communication, right? Like who are the best communicators? And I'll go back to a word I also mentioned earlier, empathy. I think in this increasingly technology driven and social media fueled society that we have, you're seeing it. Polarization's at an all time high between healthcare, the public, right? Mistrust in healthcare is at an all time high. And I think I'm seeing a lot of folks kind of dig their heels in and not building on the need to be empathetic with why families and patients might be making the decisions they are. Right. I can tell you from a public health standpoint, working on multiple different contentious issues in this space, there's always common ground. And very few families and patients that are just crazy, right? Like, hey, why are they making the decisions? There's always a reason. There's some personal experience or something you need to explore. And I think hopefully technology helps decrease burnout in other areas so physicians can start to do that. But I also think in the selection process, as you just mentioned, there are some core principles there around being able to have EQ, empathy, and I don't think that a portion of that can be learned, but there's also a portion of that significantly that needs to be selected for. And then and then
Got
and
it.
then, and then one other thing, JL, is also on the procedural side. I think it's going to become increasingly important for future physicians to be tested on their technical abilities. You mentioned that. I don't think all physicians need technical abilities, right? But surgeons, interventional cardiologists, interventional radiologists, I think that there's a lot of room for growth in testing in testing skills there that we currently actually don't do, and I think that's only going to ramp up even more. So it might be that you have two different streams over time.
Got it. Sounds good. And we've been talking a lot about it from the provider perspective. I'm also interested from the patient perspective. I've made the argument in some of the things that I've written and comments that I've made from panels that there's going to come a point where patients right now may be skeptical of AI. Right? Patients may say, I don't know. I really trust my doctor. I trust Dr. Sathya, who trained for 10 years to become a doctor, or more than a decade. But I have argued that there's going to be a point in the future where the patient is going to ask the doctor, what did the computer say? Right?
Yep.
There's going to come a point where the patient's going to trust the call of the computer more than they are the trust of the human being. Do you think that's a true statement?
I for a subset of the population, yes. I think there's going to be two groups, right? But I absolutely agree. I mean, I'll tell you. I mean, from my perspective, if I was a patient taking my kids to the hospital, why wouldn't I trust the computer more than the physician on decision making if it's incorporating data from thousands of different sources and multiple different opinions, right? It almost eventually, in my mind, is going to obviate the need for second opinions. Um, so yeah, I think that moment is going to come up quickly. I think that's an opportunity for physicians, not to run away from that moment, but to really still be that physician in the loop that's communicating even what the AI is saying, and then adding additional context and nuance and really being there for that family, right? If you have a family that really does want to lean on that, it's okay for you to lean into that as well. If you find errors, point them out. And if not, talk about your opinion in the context of all the other opinions that come. And then I think there's going to be families that still want to trust a sole physician based on their experience, and that's totally valid as well. And I think you're going to have to navigate both.
Sure. And I always say that I'm more of a Star Wars guy than a Star Trek guy, but I know that in Star Trek, which I think it's the new generation, Beverly Crusher is the doctor on board, and that's like the 24th century, and so a couple hundred years ahead of us. And I continue to believe that humans will play a role. I just think that we'll have a different set of skill set. Like I think you'll still need to understand anatomy, right? Even if the computer
Yeah.
knows everything and is telling you everything, you'll still need to understand anatomy to understand the outputs. Like, why is this recommendation being made? And I would say that to me, that's the scariest thing about younger people and younger colleagues using AI now is that people are sort of like blindly trusting the AI without understanding
Yeah,
like what that output means. And I think that at the end of the day, the proper use of AI is going to be like, hey, we understand why that recommendation was made. It didn't occur to us that that was the recommendation that was going to be made, but we understand it and we understand, why it happened and why it's the best thing for the patient.
exactly. Yes, yes. The pendulum cannot swing too far the other way either. There has to be that oversight, that interpretation. We've all seen it where lab values are out of range. For example, what does that mean in the context of whatever you're trying to assess? Is it really out of range? Is it a little bit out of range? How does it pair up with your clinical findings? What is what's been the duration of the symptoms, right? All those things I think are still going to be incredibly important because no matter what happens with the AI models, uh, even those inputs might not be accurate, but also the assumptions made from those abnormal values might not be accurate. So I think it's going to be essential to know how to interpret that.
Okay, sounds good. And then we have a couple minutes here, maybe five or so. Tell me what's missing now. Like, okay, like we know that AI is like ambient is with us now. Clinical decision support and intake is like down the line. We're doing auto coding. There's a lot of stuff that's teed up that's on the horizon. What's missing? Is there anything that like people aren't thinking about right now that, that could be useful? And maybe we can pair this with like, what would you like to see in the future? What does the future look like?
Yeah, I think that's a great question. We could go on for hours. I think there's a lot that's missing. Why don't we frame that exactly around what does the future look like? Like, what could our future clinics look like, and where can we move? I think a big area of interest, in addition to what you mentioned around intake, is really frictionless access, right? Not waiting weeks to book in clinics. How do you get specialty care very quickly? I'm seeing some startups come up in this space that are really going to optimize that process. I mean, almost 50% of the patients sometimes that I see as a specialist are not supposed to be seeing me, or they come with the wrong tests or no tests. We could totally flip that. And I think when it comes to access, which is a big consideration for all health systems and providers, there's a lot to be done there. Back office infrastructure, making sure booking is seamless. I'm seeing a lot of activity in that space. Definitely think that that's something that's going to change fundamentally in the future. And I do think that also what I'd love to see is how clinics and our practices really integrate prevention in a different way, right? We're seeing so much come out on lifestyle, wellness, prediction models. How do we think about integrating wearables so that in addition to the intake you mentioned, we're getting longitudinal patient-reported outcomes and longitudinal data that at the snap of a finger is available to us. So we actually know what's happening before that patient even touches the clinic. That's going to be huge. And then that's where we enter that whole space of home health. I think there's so much we can do without having someone actually come to the clinic. I hope that our acceleration of telehealth during the pandemic years, with current policy changes doesn't go away because I think telehealth just started to scratch the surface, right? Got someone on a video with me for me to be able to see them. But we need to take it so much further. Again, wearables, AI, how do you start making that visit really, really, really useful? Because I think it's not really necessary at times for us to see people in person to touch their belly anymore or to put a stethoscope on their chest, and I know we want to hold on to that in a lot of realms. And I'm not taking away from the fact that it is important in some situations, but I think we overblow that a little bit. And I think the way of the future is going to be different.
Yeah, for sure. Agree with all of that. And building on one of the things you talked about, I think the model that most people accept as normal is an episodic model of healthcare, right? You go to
Mhm.
see your doctor, like you get an annual physical. Maybe you get, maybe if you have a disease like diabetes, maybe you have a 2 or 3 visits a year, right? But for the most part, healthcare, even for chronic conditions, is highly episodic and very, and very high friction to have any one of those episodes, right? To just to get to talk to the doctor about your diabetes or any healthcare provider is very, very challenging. So what I have the concept that I've talked about is like just this continuous healthcare where, as you said, like we're using wearables to constantly
Mhm.
collect information on patients. So I have hypertension. I take amlodipine for it. I check my own blood pressure, but there are a lot of people who don't check their blood pressure at all, right? And I think that, think about a world where you're just being continually monitored. And if you don't hear from the doctor, everything's okay. Nothing to be done. No changes in your medicine. You're doing great. Don't worry about it, right? But you may get a call at 2 o'clock in the afternoon on a Saturday that says, "Hey, listen, I noticed that your blood pressure has been trending up. Have you been taking your medicine? Have you been, having increasing your salt intake? Well, maybe what we can do is let's see what we can do for you virtually, right? I'm going to make this change. We're going to order medication. You're going to start with a higher dose, and then we're going to check in with you tomorrow, the next day, the day after that. And then if there's no change, then we're going to bring you into the office to do a further evaluation where we might put our stethoscope on your chest. We might feel your abdomen, do the things that you talked about. But I think this idea of like continuous healthcare in which you have somebody who's looking over your shoulder all the time and is actually helping you be proactive in terms of the management of your health condition. I think that wearables, which we've been talking about for like 10 years, right?
Wow.
You remember
Yep. Yep.
there was a time where it was all about wearables, but now
Yep.
wearables plus the LLMs, and then hopefully going back to the beginning of our conversation, a change in the business model. And that's really the big thing that's going to make a lot of this possible is a model where we pay for prevention as opposed to,
Exactly.
paying for taking care of patients only when they're sick.
Yep. 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 Yeah. And the models will have to incentivize that and absolutely be a part of that. And yeah, I mean, continuous care like that could change the game in all realms. Even if you think about our post-surgical patients, we get calls all the time. Hey, we have a fever, and you say, okay, well, just watch it, see what happens, go see your pediatrician. If we could be monitoring these things, heart rate, fever, even simple things on an ongoing basis. I mean, there's tons of studies out there showing that can actually predict even infections and complications weeks before they even happen. You're talking about a couple doses of antibiotics and they'll never have an actual complication, or a different type of monitoring. So I absolutely agree.
Sounds good. All right, man. Well, I think we've come to the end here. I love talking to you, and I'm sure we could talk about this
Yeah.
for a couple more hours. So I'm sure, next time we can pick up this discussion. But I just wanted to say, Dr. Sathya, thank you very much for your time. And for our audience, I wanted to say thank you for listening, and I invite you to subscribe to our YouTube channel for future episodes. And we look forward to speaking with you again.
Thank you for having me, JL.
Thank you for joining.